All right. And here we are for episode 12 of Modern Prescription. My name is Dr. Deepak Dugar. And
I'm Dr. Jeff Toll.
Yeah, the McDreamy McSteamy.
Well, all in a day's work. Right?
And today we have a great episode. We are a full episode with an amazing guest that we're going to introduce
Dr.
in just a
Jason
moment.
Cohen.
Yes.
He is a fantastic surgeon.
At Cedars-Sinai, where you work as well.
He has a wonderful podcast that I've been on as well.
Gross Anatomy.
Gross Anatomy.
Yeah, which you can find on Apple and Spotify as well.
Yep.
And we're super excited to have him on today.
Probably a lot of our listeners would probably want to take a listen.
Yeah,
learn
of course.
something.
Of course. And we're super excited because he's going to teach us a lot. He's a general surgeon specializing in endocrine surgery.
Yeah, so we're going to talk about thyroid cancer.
Yep, talk a little bit about Chadwick Boseman, rest in peace, Wakanda forever.
Yeah.
Talk a little bit about him and his diagnosis. Talk a little bit about Elon Musk, Neuralink.
Oh, that's weird.
Fitbit for the brain. I'm super excited. Weird. I can't wait.
All right, well.
Let's do it. Thanks for listening. All right, and we are live, and we have a very, very special, super educated surgeon guest today.
A real doctor.
Another real doctor. We're killing it with real doctors right now. So this is Dr. Jason Cohen. He is a board-certified general surgeon at Cedars-Sinai with a subspecialty in surgical oncology, which is cancer surgery.
Right.
Thank you for being here.
Thanks for having me.
Yeah, we're super excited.
I feel like I should be in black, though.
I wear black every time. He switches it up.
I have a lot of different colored scrubs.
Really?
Do you wear the black socks with the black scrubs? Is that intentional or no?
I think that was by accident.
Okay.
I tend never to wear black. That's one of the colors I just don't wear for some reason. I like the blue. I think it looks better on my skin, but not so much black.
So you're watching the video, you see how handsome Dr. Cohen is, and that's why he's worried about his scrub look.
There you go, exactly.
Well, wonderful. Thank you for being here. And tell us, what is a general surgeon? Because people know what surgeons are.
People don't even know. That's a good question. What a general surgeon. So, actually, a general surgeon is becoming more and more rare these days, or all types of medicine are. So basically, you do 4 years of medical school, and then after those 4 years of medical school, you do residency. And general surgery residency is anywhere between 5 to occasionally 8, usually anywhere between 5 to 7 years.
After 4 years of med school.
After 4 years of med school.
After 4 years of college.
After 4 years of college, exactly. And often these days, a lot of kids will take a gap year or do like a research year to get into school. So it could even be more.
Wow.
And in general surgery, you basically learn the gamut of all sorts of surgery. But after you finish, you're pretty much expected to be able to do gallbladder surgery, appendix surgery, intestinal surgery, breast surgery, even head and neck, thyroid surgery, some aspects of plastic or even cosmetic surgery. You're supposed to be able to do a little bit of everything.
And trauma, for sure, right?
Trauma, for sure. And critical care.
Yes.
These days, except in in big communities with big major teaching hospitals, being a general surgeon isn't necessarily as common anymore. Everybody kind of subspecializes and has a little specific interest and niche. But there's still a need for general surgeons, especially in the community and especially in terms of trauma and acute care stuff.
Yeah.
Yeah.
So I have a special place personally of general surgeons because I had a ruptured appendicitis as a kid.
Ooh.
Wow.
Had peritonitis, was in the ICU at Cedars-Sinai.
Wow.
David Familia, who you probably know well, saved my life.
Wow.
And then that was complicated.
How long were you in the hospital for?
So that was for about a week.
Wow.
Ruptured appy. Bad.
Wow.
Then I actually had that complicated by a bowel obstruction about 2 months later.
Wow.
How old are you?
And that was a gangrenous bad bowel obstruction, resected like 4 feet of my bowel.
Oh my God.
Again, David Familia.
Wow.
Whoa.
So David was
What kind of scar do you have? I want to see your scar.
I have a ventral scar.
Do you? A midline vertical scar?
Yeah, midline vertical scar. Yeah.
And also an appendix
the old school
scar?
appy open, yeah.
So you have
it just blends in with your six pack.
Yeah, I'll show it to you after.
Yeah, we definitely should. You should put that on the podcast for sure.
So, in any case,
How old were you?
David Familia, Dr. Familia, I was 11 or 11 for the first, 12 for the second.
Wow.
And so that was actually why I wanted to become a doctor. And I remember during my residency, I ran into Dr. Familia in the elevator. Obviously, he didn't recognize me. I was an adult. And I told him, he saved my life as a kid, and that's why I became a doctor. I think he was pretty touched by hearing that.
Wow,
Yeah.
that's such a
Did
cool
you give him
story.
a hug?
Yeah, I gave him a hug.
Nice.
Yeah.
Can't do that anymore.
Yeah,
No, I
not
can't
anymore.
hug now.
No.
Nice
Elbows.
nod I could do now.
So why didn't you go into surgery?
You know what? Honestly, we've talked about this before on the
He wanted
show,
to be an
but
orthopedic surgeon.
I thought when I went to medical school I wanted to be a surgeon, but it doesn't play to my strengths. I'm much more of a big picture problem solver. I can kind of like take a lot of data and distill it down to small bites that like I can explain to patients.
Right.
But I'm less incredibly meticulous and patient.
Right.
And so the idea of a surgery where you have to just go one stitch by one stitch, or these little like dissecting little nerves out and vessels out, that's not.
Well, you could have become a bad general surgeon.
I would have been a bad surgeon.
Right, exactly.
I would have been a bad surgeon.
Yeah,
I would have like broke the sterility. I wasn't good at it.
Wow.
I respect it a lot because it's something I'm not good at. And that I think, and it's amazing because, what I mean, sometimes I save someone's life in the sense that I diagnose
for sure all the time.
this or that,
Yeah.
but it's less where like you really like you save their life.
Right.
Like they would be dead.
Have you had any intestinal issues since then?
I think I had post-surgical, what I would call like IBS type of symptoms, maybe for a couple years as a teenager.
Yeah.
But I think I sort of grew out of it. Now
That's
it's
good.
pretty much
Eat fine, go to the bathroom fine, all that stuff.
Yeah, I think all the fans want to hear about this.
Yeah. Well,
Yeah, I think the honest truth is I'm probably not quite normal, but to me it's normal enough that it doesn't affect. I don't think about it. Like, do I sometimes have whatever issues more than the average person? Maybe I don't really know, but it doesn't affect my quality of life for a day.
As a surgeon, I don't want to scare you, but we have patients that come in with intestinal blockages, bowel obstructions, and the two most common reasons why patients get bowel obstructions are either one, internal hernias, and two, scar tissue from previous surgery. Yep. So that's why I asked you, like,
I was
to
number
some
2.
degree,
I had adhesions for sure.
So you probably still do, and to some degree, something to be aware of is like if you ever start getting like a tummy ache or something, just put yourself on liquids right away and don't try to eat through it, kind of thing.
Yeah,
great advice.
I think very likely I had very bad adhesions from the peritonitis. It was just probably all scarred up in there.
Yeah, I would not want to operate on you.
Wow.
Yeah, no, it would be avoided at all costs.
Yeah, exactly.
That's such a good point because surgeons, we love normal anatomy.
Right.
Any abnormal anatomy makes surgery so much less fun.
Yeah.
Exactly.
So much less fun.
We hate scar tissue.
We hate scar tissue.
I know.
General surgeons in residency, when I would train at UNC in Chapel Hill, they were always like the bad boys, like in a good way. Like they just kind of had like
not the orthopedists.
The orthopedists, we kind of didn't. It was different because they didn't know anything.
Yeah.
They would come and fix their little problem and leave. But like being in head and neck surgery, we did a lot of free flaps. So a lot of our patients were in the ICUs, and that's where general surgery land, right?
Yeah.
You guys run the ICUs. You guys are the kings there.
Yeah.
And so whenever you're in there, it's just so. I always just looked up to general surgeons so much because you guys are just the smartest.
They're real they're
like super doctors
and surgeons.
And surgeons, yeah.
Well, that's why I decided to become a general surgeon. But you're ENT trained.
ENT background.
So you were someone that I looked up to. So as an intern on my first year of general surgery, for some reason, they gave me 2 ENT electives.
Oh, so cool.
And I was in Brooklyn, at SUNY Brooklyn, downstate.
Great program.
And there was a great ENT program there. And those guys were the cowboys, the ENT guys. And the residents got to do, there was barely any attending supervision. And all the residents did all the flaps and all the wax.
Yes.
And I really fantasized for a long time about going into ENT. And I really wrestled with, at one point, should I switch and go ENT?
Well, it's funny because you've full circled now. You specialize in surgical oncology of the neck.
Right, exactly. And that was kind of why. Like, it was part of my ENT experience that I said,
thyroid and
let me do
parathyroid.
thyroid, parathyroid. Exactly.
Interesting.
Yeah.
That's so cool. So tell us.
So I want to be you and you wanted to be me.
I know.
There you
Should
go.
we all just switch?
We
Exactly.
can switch seats. That's good enough.
Nice. Get some music, play
We
musical
all want to have
chairs.
Jeff's hair.
I wonder if we were
I
like
used to have
stuck.
that hair, but now I hit 50 and forget it.
I wonder if we were stuck. Like if I was really stuck in the wilderness or something, but yet had surgical equipment, could I take out someone's appendix or something? Probably not.
Probably not. I wouldn't be able to. We'd be able to compress the bleeding.
You could.
I couldn't take out the appendix.
I think
that's
you could.
Well, I kind of think the same. Like if someone wanted me to do like, a code or CPR,
A code I can run for sure.
I couldn't do that because I don't
do.
do any of that stuff anymore. But you could.
Yes, I can.
So let me ask you a question. If you're
Just
on
in
a
the
plane,
car, I'll tell you this. On the car on the way here, I got paged by a nurse. So I have a patient in the hospital currently who had a intracranial bleed and was in the neuro ICU, had a drain. We just brought her back out to the regular hospital 2 days ago, and they just called me that she was seizing. So I basically was running the seizure code on the cell phone. On the phone with the nursing.
I couldn't do that.
Right. So we were giving her some Ativan to make the seizure stop.
Maybe, right?
Yeah. Well, you can load them with Dilantin later on, but basically immediately as you give them some Ativan and try to bring them. In any case.
So if you're on a plane and they say, hey, is there a doctor on board? Are you one of the first people to raise your hands or one of the last?
Yeah, I would help.
Yeah, I do
I'm
too.
a little slow. I have to confess.
Yeah.
But my wife's a nurse. She's like, she'll raise her hand right away. So I'll be like, go.
The only reason I raise my hand is because I'm an airway expert. Like,
that's true.
From being ENT residency, like nobody, like that was the one part about being an ENT residency. Like when you're in the hospital, like you just feel like the king of airways.
Right.
Like anesthesiologists look up to us for
That's true.
airway help.
Right.
At the end of the
You
day,
guys are
we're the surgical airway experts.
Right.
Like in the ICUs, you guys used to do like the through the whole percutaneous trachs, like we used to like make fun of it, like because it just that's not a real trach, you know, and that causes so many complications for fistulas.
Actually, I watched as an intern one of the ENT attendings do a trach on an impossible neck, and this guy Gotti Harrell.
Okay, yeah,
unbelievable. Like I just said. ENT, they know how to do trachs.
Airways,
it was amazing.
Yeah, so I always think about airway because if someone's having a heart attack, I have no idea what to do.
Yeah,
but for airway stuff,
I find a doctor if someone's having a heart attack.
yeah, a real doctor.
Yeah, exactly. Yeah.
Well, what is your? You were telling us that this is Thyroid Awareness Month.
Thyroid Cancer Awareness Month. Yeah, September.
Explain that. What is thyroid cancer? What is the thyroid? Explain a little bit about that.
There you go. Some medical stuff.
Yeah.
So the thyroid looks like a little bow tie or butterfly. It's right on top of the windpipe in the middle of the neck. And around the trachea, around the windpipe.
Mm-hmm.
And the whole job of the thyroid is kind of to regulate our body, like our activity level. If it's overactive, if it's normal and perfect, we're fine. But if it's overactive, we're sweating, our heart is racing, we're losing our hair, we're going crazy. If it's underactive, we're sluggish, we're gaining weight no matter how hard we work out. We just don't feel good, no energy. So that's the whole job of the thyroid. So some people have problems with the thyroid in terms of function, but
those things I fix.
What's that?
Yes. That's the things that I fix.
Yes.
Right. Exactly.
And then when do you help with the thyroid?
I tend to help if either it's non-fixable, like occasionally someone's thyroid will be overactive and there are medicines to treat it, or sometimes getting radioactive iodine. And sometimes either those have, they've tried it and failed, or sometimes it's not an option for whatever reason, pregnancy, young age, certain things like that. And then we say, we got to get this thyroid out so that the overactivity of the thyroid isn't happening anymore. And then we go back to you to find that perfect medicine level for the thyroid. So that's one reason. And then the two other reasons is some people get what's called a goiter, which is like a giant thyroid. For whatever reason, the thyroid grows into a huge tumor-looking mass, and it could start affecting the airway, your area of expertise, either by just moving the trachea, the windpipe over, or squeezing it to, and occasionally you'll get these emergencies where the windpipe turns so narrow that the patient's kind of breathing is like, and they could barely breathe. Scary. And that turns into surgery. We tend to want to do that sooner than later. Sometimes patients will even say, my exercise tolerance is down. I have trouble swallowing, trouble breathing. So that's another reason. And then lastly, cancer or nodules or growths is why we do surgery too.
So I was going to ask you about that, about the thyroid nodule thing. So a lot of, especially I think women tend to get these nodules, or at least notice them. As far as my patients will feel their neck.
Almost 2/3 of the population have thyroid nodules.
Right.
Bingo.
2/3 of the population.
Yeah, I mean it's like getting beauty marks, freckles. It's kind of the same thing. Women with little lumps and bumps in their breasts and mammogram abnormality. It's just so common because the thyroid's a hormone. It's constantly changing. It's regulated. So because of all those changes, constantly little bumps or beauty marks or blips pop up.
So a lot of times if someone notices a thyroid nodule or something, we'll take an ultrasound.
Right.
And then when would you say, so sometimes the radiologist will say, cystic nodule.
Right. Yeah.
When is it worrisome or is it in general?
Yeah. And it's constantly evolving that a little bit. And a lot of it is dictated by radiologists and data. But, what makes a thyroid nodule worrisome when we're not just talking about size and compression is, the different features that they see on the ultrasound. If there's a certain weird blood flow through it, if it's a mixed solid and cystic nodule, if there's calcifications in it, if it's an irregular nodule, funny shape, and sometimes even a teeny tiny nodule could look suspicious. And sometimes a really big nodule, could look totally fine and you could keep an eye on it. And then there are different criteria based on the mix of size, shape, calcifications to say, just keep a close eye on it, repeat an ultrasound versus do a biopsy and things like that.
And then am I right that thyroid cancer is one of the cancers that affects, first of all, younger people and then also women? So it's it tends to be women actually more than men.
Right. Women more than men. It's not uncommon to see it in young people. And I must confess, one of the reasons why I like treating thyroid cancer so much is, and the best part of telling a patient that they have thyroid cancer is about 97 to 99% of the time it's treatable and curable with surgery. And it's such a benign acting cancer that in Japan, in Asia, they've been studying it for a long time. And we're starting to do it more and more here in the US. Just like with prostate cancer and active surveillance, they're kind of small, favorable-looking thyroid cancers. We do a biopsy. We know it's thyroid cancer. It's such a benign-acting cancer that in some people, we're saying, let's just watch it. Let's just keep an eye on it and not even operate.
Wow.
It's cool. I don't like that because then I don't get to operate.
And as a patient, that's kind of scary.
Some patients are, right. So some patients I'll say, you might be a good candidate for us to just keep an eye on it. And they're like, what are you, crazy? It's cancer. Let's get it out. And I'm like, I'm a candidate. But then I've had other patients who I think, and the endocrinologist, the medical endocrinologist, we both think the patient should have surgery and they're just looking for any excuse not to. And it's real, as a surgeon, it's so hard to every few months to have them come in and be like, okay, we're watching your cancer, we're watching your cancer.
Right.
It's a stressful thing as a surgeon, but it's such a benign acting cancer that we do that.
Yeah, because in prostate cancer, I have that conversation at least once a week, if not more, where we know someone has cancer and we are following their PSA and repeating the imaging, because prostate cancer is actually so common for men that most men, if you do an autopsy and you take apart the whole prostate, you'll actually find prostate cancer in like 80% of them.
Right, and the same kind of studies were done with thyroid too on autopsies.
So they will die with the prostate cancer, but not of the prostate cancer.
Right.
And so someone, especially if someone has other medical problems, like they have terrible heart disease or dementia or something else where they're going to die of something else, unfortunately, before the cancer even affects them, then there's no reason to put them through the prostate surgery.
Yeah.
With thyroids, you were saying that usually ultrasound is the method, right? With ultrasound, isn't that based on someone doing the procedure and reading at the same time versus like an x-ray where like you take an x-ray and it goes to a room with a single image that multiple people could all read at the same time?
Totally. So to some degree, it's dependent on who's interpreting that ultrasound. It's and who's doing it.
Yeah, that's kind of scary,
A little bit. So you definitely, some patients will come in with an ultrasound from outside and I'll be like, no, I'm sending you to this place so I could have it.
So you have people you trust with the ultrasounds.
Where do you...
And there are a lot of doctors who do their own ultrasound, a lot of ENTs and surgeons who do thyroid. I don't.
Yeah.
Part of it is a political reason. I get my referrals from the people who do it. A lot of the medical endocrinologists do it themselves.
Sure.
So, or the radiologists. So I don't want to step on any toes.
Yeah, team approach.
Yeah, exactly.
And then I think obviously you're in a group with other surgeons who do all these other things. And obviously this week we learned the bad news about Chadwick Boseman.
Yeah, the Black Panther, rest in peace.
So, which was obviously shocking for all of us. And I guess, I don't know what my question is, but,
I don't know what your question is either.
Well, it seems odd that, he's such a young guy.
Such a young guy.
Is colorectal cancer that common in young people?
You guys probably see it too. I mean, younger cancers seem to be on the rise. And I don't know if it's just A, the population is growing like crazy. B, we're just more aware of it. But, what tends to happen is, especially when you're in medicine, you see these young people showing up with cancers who out of nowhere, and it's devastating and heartbreaking.
Yeah.
So,
yeah, I mean, I think there's probably environmental factors,
Right.
like all the processed food we eat,
For sure.
things we have all around us, you
Right.
know,
right.
that are a contributing factor.
But we
'Cause
also
we don't typically start screening. So colon cancer is like the third most common cancer in both men and women. So basically, lung cancers are very common, prostate cancer is very common, and breast cancer for
Right.
women. And then basically colon cancer is the next one, right?
Right.
And so the typical guidelines are to start screening around age 50, unless you have family history of either colon cancer or some other cancer that may be associated with having colon cancer risk. Is that
right.
accurate?
Or you have pretty much, or you have some kind of weird, vague symptoms, you know?
Right, sure.
Right. Change in bowel movements, anything like that. And I think there's, at least so far, there's an underappreciation of family history and stuff like that. So I think we need to be more aware, all of us as docs, you know, when we take a history from patients, I think we need to be more aware of asking about family members with cancer and what age. That, you know, if someone says, oh, my 97-year-old grandmother had colon cancer, yeah, that should trigger, you know, if five grandmothers did, that should trigger you. But certainly, you know, my 50-year-old someone had cancer, then I think it's worth genetic testing.
And
So
I think
that's
a
the
great
question.
point for patients too,
Yeah.
to keep that in mind, that sharing the family history and knowing your family history when you go to the doctor is so
Yeah.
important.
I think
a lot of patients have no
people
idea.
don't know.
Yeah, they don't know.
Yeah.
And that's
it's
scary.
Extremely helpful.
Right.
I think
right.
a lot of times for me, when I'm doing my preventative wellness exams,
Yeah.
especially on patients that I know well, so maybe if they're very complicated the first time I meet them, I can't really delve into it. But
Right.
after you know a patient for a while and you can really delve into it more, I think you can also customize, like the recommendation, the government gives us certain, or government or the,
Right.
whatever, the American,
Medicare or whatever,
American
yeah.
Medical Association, all these things, they recommend certain things. And then Medicare, which is what pays for a lot of these things, bases their reimbursement off what the societies have recommended. So,
Right.
but some people, if they can afford it, if they have a family history, may consider. So for example, anyone who has a family history of pancreatic cancer, really at any age, for example, there's no guideline to screen at all.
Right.
Even if you have a family history of
Right.
pancreatic cancer.
Because there's no good screening, at least not yet.
No cheap good screening.
Right.
And so that's why
And no reliable good screening.
well, yeah, well, if you do it like an MRCP, MRI of the pancreas, you can get a good picture.
right. But it doesn't
It's just
necessarily mean it. It's less interpretable.
And what do you mean by that?
Like you get a normal MRI, what does that mean? That just means you're okay today.
Yeah. But
In
that's
terms
what
of
all,
screening, though.
but that's what all the screening tests are.
Right, but you're not
good
going to
today.
necessarily pick up. Well, sometimes you could pick up cystic lesions in the
Yeah.
pancreas, but
Wouldn't that
it's
show up
not
on a
like
PET scan?
usually
No.
too late. Usually
Too
it's
late,
it's
yeah.
it's already a centimeter if it shows up on PET. But like with breast cancer, we do mammograms because the calcifications that show up in mammograms usually are early stuff and you could catch it. Whereas the problem with pancreatic cancer is when it's found, it's often too late because of the location, even when they're small.
But isn't the reason it's too late because we're not screening?
yeah,
so by the
maybe,
time-
perhaps.
Because what I've done is, at least with my patients,
Right.
is I have a radiologist that I negotiated a cash rate with that's
Yeah.
reasonable. And so if people want to get an MRI, we do that as a screening test. Because at least my thought behind it is, I mean, sure, is it possible we miss something? Maybe,
Right.
but you're more likely to catch it earlier if we're screening.
Right.
Same
Part of the
thing
problem
with-
with pancreatic is we don't really know for sure what to do with the findings of like cystic
Yes,
lesions
sure.
in the pancreas.
Right,
How-
right.
And in order to do surgery and biopsy those things, that's a big surgery. You know,
That's a great point.
whereas with breast cancer, you just do a needle biopsy.
Right.
It's fairly easy. It's not very invasive.
Mm-hmm.
Low risk of complications.
Yeah.
So
Yeah, have you ever done
well,
one of these
at-
pre-screenings and found
at
something?
Cedars-Sinai, they have an advanced endoscopy
They
team
do.
that's very, very good. And so a lot of times what they do is something called an EUS,
Mhm.
which is an endoscopic ultrasound. So it's basically you do a endoscopy. So you put the camera down, which is what you typically do to look around in the stomach or the upper GI tract. And you can actually navigate it down into the duodenum, then back up into the pancreatic ducts and actually put an ultrasound right next to
Right.
these lesions and get a good look at them. So they're
and they could even do biopsies through that too.
Biopsies there. So we're lucky at our big, center that we can do that.
Yeah, but
probably
common America
can't be
do
done
that.
in most hospitals
No
in
way.
the U.S.
No.
Not like going to get a mammogram kind of thing.
No, absolutely.
Right. And if something goes wrong with a mammogram, with a biopsy with a mammogram, the worst thing is like a hematoma, which is horrible, a big blood
bruise.
clot, a big bruise. But if something goes wrong with the pancreas, you can get pancreatitis and die. So with that biopsy.
Yeah, so that's a great point. Have you ever found any positive findings in these prophylactic screenings?
I haven't really, but they're not that, as the number of patients I have who have strong, have a family history of pancreas.
Yeah.
It's, a dozen or.
And again, the reason we're talking
it's
about
not
pancreas so detailed is because the death rate is so high with pancreatic cancer.
Yeah, so the pancreas cancer is not.
It's not like thyroid cancer. It's the
not
exact
common.
opposite of thyroid cancer.
It's the exact opposite. So thyroid cancer is common and very curable.
Right.
And pancreas cancer is uncommon but extremely deadly in most cases, often because it's found too late to do anything about.
So with the thyroid cancers, I want to bring it back to that for a second. Typically the surgery is a little incision in the neck.
Right.
And it heals really nicely. There's a little tiny scar.
Right.
There's been a few celebrities who've opened up about their thyroid history, which has been great for patients.
Yeah.
What's the deal with these transaxillary thyroids that you hear about once in a while? There'll be like that one guy in every city who claims to do it.
So I was that one guy.
You're the guy. Okay, awesome.
So robotically, robotic surgery with the Da Vinci, which is basically, I don't know if you've seen have you guys seen the robot?
Yeah, we used to use it.
So it's a giant machine. It's really big and bulky. And basically these robotic arms plug into the instruments, and then you sit at this amazing 3D viewer console, and it's basically like playing a video game with amazing visualization. So it's probably about 8 years ago, I started doing robotic surgery for the reason to do thyroid surgery. That's transaxillary, exactly.
Meaning cutting your armpit.
Exactly. Yeah, and I learned it from an ENT surgeon. And I went around and I practiced on cadavers, and I did 2 cases. I did a thyroid and a parathyroid, the parathyroid are 4 little glands that live next to the thyroid that control our calcium in our body. And
they're tiny, size of a lima beam.
Right. A lentil or an apple seed, exactly. Yeah. So you make a 6 centimeter incision in the armpit, which is a big incision, whereas a thyroid incision, I'll try to do, maybe an inch or a little bit bigger than an inch sometimes, but you do a 6 centimeter incision in the armpit, and then you have to dissect up over the pec muscle, under the skin. You have to make sure you don't get into any weird thing. You get under the big neck muscle here, the sternocleidomastoid, right? And you get into the space where the thyroid is. Just doing that was stressful and a lot of work. It was it was really easy on the cadaver, but when I finally did it on a patient, you're working hard, and that's not robotic. That's like boving and dissecting and someone lifting up with a retractor and working hard. And then you get into the space and you what's called dock the robot. You put the robot in, you set it up, and everything's almost already dissected at that point just to get to that space. And the surgery part of that was actually nice and elegant and stuff like that. And I did a thyroid, one side of a thyroid that way on a young girl. And then I did a parathyroid the same day. 2 things happened after that. One, the girl came back. Luckily, it was benign, so I didn't have to take out the other side.
Amazing.
What was amazing is she came in after her thyroid surgery, no scar in the neck. I mean, that's the motivation, no scar in the neck.
Huge.
But what was crazy was for months, she said she couldn't shower without it killing her. She got what's called paresthesias.
Yeah.
Just like pain, like pins and needles from showering.
So struck
all
a
the
nerve
dissection.
or something.
Yeah. And that's a common finding. Luckily, it got better, and eventually she was no scar here and a little scar that hidden under her armpit. That was great. But just having to worry about that, is it going to get better, freaked me out.
Right.
But then the Da Vinci company, Intuitive, right when I started doing it, said, you know what, this operation, it's kind of not, it's a little out of the box. They pulled the support.
Got it.
So those were my first and last 2 thyroid and parathyroid. Now, there were some people ahead of me on the curve who are still doing them. There's a guy in Korea who does a ton of them.
Yeah. They publish articles every year on it.
Right.
Yeah.
And the truth is, I think there's definitely something to it. I think when the robot, now it's this big, giant, clunky thing. When it shrinks down and they really make it more of a micro thing and you don't need a huge incision, I think there's going to be a role for it. And I still do a lot of robotic surgery for other stuff. So I think I actually, every time I see the reps, I'm like, when are you guys going to, get me to do more stuff and work with your company to try to figure out how to... But I think they got burned with it a little bit when they first tried doing it.
And with robotic surgery, just to clarify, so a lot of people think robotic surgery means a robot's doing the surgery.
Right.
That's not what it means at all. It means
way.
there's a console that has robotic parts that the surgeon is manipulating and moving.
Totally.
The surgeon's doing everything.
All the work.
Yeah, so robotic surgery just means that it's be robotic assisted is the right term.
Exactly.
But a lot of people get confused.
Right, but what you could do is, we're in the room doing the surgery. Theoretically, you don't need to be in the room.
Right. Unless there's a complication that requires conversion into an open surgery.
But there's usually two surgeons or in the room. One's at the table, one's doing the robotic part.
Yes.
But the nice thing about the robotic surgery is when you do just laparoscopic surgery, regular instruments, it's like kind of scissors. It just opens and closes, and with the robotic instruments, it's like a full rotation of a hand, and it's so fine-tuned. If you have any tremor in your hand, the robot takes it out.
Yeah.
So it's really cool. Have you ever had a chance to play on the robot?
I've seen it. I've never used it.
You should play. I mean, it's a lot of fun.
We used to, in residency, practice and do robotic tonsillectomies once in a while because we would do like posterior pharyngeal, tours. And we do posterior pharyngeal tumors where it's just so complicated to do that open because you literally have to split their entire mandible, open their entire face.
Right.
Versus with the robot, you get that extra curve and you can all of a sudden dissect in the back of the pharynx.
Exactly. That's the other nice thing about it is, our hands are this big doing surgery, whereas the robot arms are small, so you get into small spaces.
They can bend in weird ways where we can't.
Really cool.
So, but speaking of robots, I'm super excited because robotic surgery.
Ooh, that was a nice segue.
Yeah. Elon Musk, Neuralink. It is a Fitbit for the brain and skull. He just did his first product launch demo on Friday. Like Steve Jobs used to do his big product launches for the iPod. So he did his first one. He brought out 3 pigs, the most famous, beautiful one named Gertrude. Okay. And he has now installed these on dozens of pigs. And what it is basically he's making a little curvilinear incision in the hair is the plan that he's going to now drill into the skull being 7 to 10 millimeters thick. He'll drill about 4 to 5 millimeters, implant the actual device, which will be about the size of a quarter.
It's the Matrix.
Yeah, it's just literally just like the Matrix because what the quarter has attached to it is all these electrodes that'll go in about 2 to 3 millimeters in the brain matter tissue. Okay. And all of this is supposed to be done. Now, this is different from what we just talked about. This is supposed to be done by a robot.
Wow.
No surgeons involved. Surgeon is supposed to be on standby for emergency only.
And then what does it do?
So the whole concept is like right now, people with Parkinson's have implants. People, deep brain stimulation implants. Mm-hmm. About 150,000 people in America have these. And they help people, but they're kind of like archaic. It's like the example he gave is like, remember like in the 90s when your TV would mess up and you just kick the TV?
Right.
And it would just get better sometimes. It works sometimes. That's what a deep brain stimulator is. It just gives an electric current to give you a little bit more power to the tissues that are not getting enough power right now.
To the dopamine centers.
Exactly. So what he's planning on doing is using this initially for paralyzed patients, so people who are paraplegic. He wants to try to stimulate the regions that would control those parts of their bodies. So on these pigs, what they did that he installed these in, they mapped out on the brain of the pig the elbows and the wrist and the ankles and the hip joints. They mapped it out, and then he predicted where the movement patterns would be based on where in the brain it was. And then once they installed it, they were getting feedback from it. So this is a read and write system, which has never been done before. So most of these deep brain stimulators, all they do is give stimulus. Right. They don't read anything. They're not able to transmit information. Gotcha. So this is going to be able to transmit information and deliver stimuli, which is brand new. No one's ever done that before.
So it can learn.
It can learn, and it can...
Is he going to put him into the spine also, or just the brain?
So the plan right now is the brain, and what he kind of copied initially was what we used to do in residency. Again, everything comes back to my residency, but cochlear implant. So in residency, we used to do the surgery where you would drill in the back of the mastoid. The mastoid is a huge open, kind of like a honeycomb, and you can drill, and there's a lot of empty space in there. And then you can put what's called a cochlear implant by putting a little fine wire into the cochlea when the cochlea, which is the hearing part of the ear, doesn't work anymore when you get older. So Elon Musk basically copied that idea. And so his first iteration of this that came out a year ago was behind the ear. And then basically, I think after they realized the behind the ear is not easy access to the brain. It's very complicated, very, very complicated, because you're getting into these areas that are very, very, you have the cranial nerves, 8 and 9 in that region. And it's just very hard to work in. It's a very small apex window versus the top of the skull, huge open territory. And so it's just much easier. It's much easier for a robot to do it. Back of the ear, it would have to be a human surgeon.
So pretty much while you're fixing people's noses, Elon Musk is flying to Mars.
Right.
He's digging underground so that you can get places very fast.
Yep.
He's giving you electric cars.
Yep. The most valuable
He's
electric
giving
car
you
company in the world.
Solar panels.
Yep. Starlink is launching through
he's
SpaceX.
naming many children many weird names.
Yep. And
How
listing
many
all his-
children does he have?
I think like 6 or 7, right?
Wow.
Well, his
Someone has to
newest-
inherit all these
Right.
I know, amazing companies. Well, his newest child, he gave the really weird name with the weird symbols in
Yeah,
it.
it's
All the same wife?
No. The latest one was with that artist named Grimes, and he joked around with
He has an interesting
Neuralink. He was like, you can
personal
stream
life,
her album.
sex life, personal life.
Yeah, he in
There was
the
those
Johnny
stories
Depp.
about Johnny Depp.
Yeah, that came out through Johnny Depp's legal case with his ex-wife Amber Heard.
Right.
That there was a threesome at some point with Amber Heard, Elon Musk, and the model actress that was in that movie. What's her name? The one in the Will Smith Batman movie, Suicide Squad. Forgot what the girl's
Margot
name
Robbie?
is. Not her. The other girl. She's the model actress.
I don't know if you knew this, but Dr. Cohen is a movie buff, movie expert.
Movie
Big movie
expert.
Although I can't come up with what you're talking
No,
about.
it's okay. It's
Yeah.
okay. But anyways, yeah, supposedly threesome
That
responsibilities.
sounds pretty good.
But
he earned
he lives
it.
an interesting life.
So it may not be his kid then.
No, I think this one is.
This is his kid.
But yeah, it's really interesting. The Neuralink is like supposed
Well,
to
what's the big
change the
picture
world.
plan for that? Is
The
it going
big
to be
picture plan is to cure all neurological and improve all neurological function. So paralysis,
but it's not
depression,
like it's not like
strokes.
having a computer in your brain.
No,
kind of thing.
no,
It's
no.
not,
It's meant to
so
give-
it's not like the Matrix. Kind
Not
of thing.
like the Matrix, but depending on how the advances
Once
can
you
get
can
in the future.
interface, yeah.
Once
Right.
you can interface better, it could be the Matrix.
Right.
Learn a language, just click a button.
Guys,
Right.
very smart.
And the coolest thing is, so the device itself will link to your phone. It works through Bluetooth. It charges overnight when you're sleeping, and it has all-day battery life. And so it literally works through your phone. You literally program through your phone, just like the
Wow.
Tesla gets updates
Yeah.
as you're driving. Same thing will happen with this thing. You'll get continuous updates. So
Would you sign up for one?
I would definitely sign up for one after it's been
Yeah,
done
yeah,
on
yeah.
a few thousand people.
Yeah.
Yeah.
That's how I feel about most of his inventions. I wouldn't be on the first spaceship to Mars either.
No. But I would get Starlink as soon as it comes
I
out.
would like to go to Mars.
Go to
You
Mars.
think? Well, I think what he's planning, with
6-year
space.
trip.
Is it 6 years?
Yeah, it's a long trip.
Oh, I didn't know.
Yeah,
6
Mars
years.
is not a quick
Oh.
thing.
Why not the moon then? Does he go to the moon?
There's nothing on the moon. There's no resources.
There's nothing on Mars.
There's nothing on Mars, but the goal is that if you can get there fast enough, it has potential.
I thought what he was because NASA gave him money to help make rockets better, which he is now able to land the rockets and like.
Totally.
It's way better
He's
than
done
NASA.
way more than they ever did.
But I thought part of his plan was to have commercial. Maybe it's to the space station. Maybe that's what it is. Where
Yeah.
he's going to let billionaires basically pay to fund like the NASA projects and
Right,
everything. They're
right.
going to let billionaires pay to go to outer space.
Don't they already have some people lined up to
I
do
think
that?
Yeah,
I
Virgin Intergalactic.
think Virgin was trying to do it for a
Yeah.
while too.
I
I
think
think
they have
people have
people
already
signed
bought.
up.
Yeah.
Yeah, they
And I think it's
prepaid.
coming up pretty soon.
Yeah.
Isn't
So
it?
I guess
Yeah.
I'll be able to afford to go probably the next year or two.
Right, exactly. Depends how your phone call
Yeah.
goes today.
Yeah, with all your COVID testing.
Yeah,
The money's got to go somewhere.
Yeah.
That's funny. No, but I'm super excited because I think that this could be like revolutionary kind of medical technology. Like the way that he thinks about every industry is just so different from the way that we think about it in terms
yeah.
of fixing problems. He's thinking about interfacing in a whole new way.
Yeah, I think medicine will be a lot of artificial intelligence will help too, because in diagnosis and in, like I think there's a lot of cases where someone seeing their local doctor or even all the experts at that hospital, let's say, can't figure out a case, but in a computerized system, they may suggest other
Sure.
labs to order, other.
Did you
Right.
ever see there were 2 TV shows that I don't think either of them did that well?
On Netflix, I saw that one. The Mystery.
Ann Curry was one of them.
Yeah, maybe.
Was
yeah.
hosting one of them. about unknown diagnoses and trying to crowdfund, crowdfund. And it was an interesting
Very good
premise,
idea.
like that.
Very good idea.
But I didn't think the shows were done that well. But
I agree. The idea
were cool.
The idea to do that was very cool. The show didn't turn out as well as I hoped it would when I heard about it. But I totally agree.
The idea is so cool.
Yeah.
Because
and one of the hosts on the show was a former surgery resident at Cedars-Sinai.
Oh, really?
Gotcha.
And then he segued and he was the host on that
Into
show.
entertainment.
Cool.
Oh,
Right,
very
exactly.
cool. No, because you guys are spoiled because you guys work at one of the best hospital systems in the entire world.
Yeah.
Like in the
It
universe.
really is, for sure.
And then there's doctors who work in, small towns in Kentucky.
Yeah.
And the general surgeon there does everything.
Right.
Because he's the only one.
Although as lucky as we are doing that, I reminisce. I like to tell a story. I spent as a fourth-year medical student. I went to Kenya. I worked in a mission hospital.
Wow, yeah, that's real wild west.
And I remember a patient there dying in front of me, and I had no idea what he was dying from. And we're all trying to figure it out. And he and his family just kept thanking us, even because they knew we were working hard and trying to take care of him and keeping him as comfortable. But we by no means helped him. But yet he and his family, even after he died, just kept thanking us.
Wow.
You see that in rural areas in third world. The hospitals where we work, you don't get that thank, even if things go well. So, there's a good and a bad to what we're used to.
Totally.
Yeah.
That's the gratitude part of it. The small towns and the small cultures have way more gratitude.
And that's one of the things, one of our hot topics on this show is figuring out for each person, and that we both talk about with our patients, what makes people self-satisfied and self-happy without the need for someone else to give you the pat on the back or say good job. And so I think, for me, that's a big part of, since I'm doing a lot of preventative care, a lot of it is not just how do I give you a medication for your diabetes, but how do I make you feel good about yourself, to want to change your life, to want to do these. And I think, you do a lot of making people feel good a lot about how they look, whether they want the surgery or not. And sometimes telling people, why would you get surgery? You look great.
Oh, yeah. Some of my biggest regrets are nothing to do with the surgical outcome. It's the patients, and whether or not mentally they were able to understand the value of doing this procedure. And I think a lot of people lose that.
A lot of doctors, especially here in Los Angeles, we work it's so competitive. You work so hard. You work so many hours. And if the patients aren't giving you that feedback, you need to give it to yourself, because you're saving people's lives. You're helping people, and to try to remind yourself of that at times.
Well, you're lucky because you get to cure people's cancer on a regular basis because you focus on thyroid and parathyroid, which is an amazing
But you cure
specialty.
depression by fixing everybody's noses.
No, I disagree with it, because I actually, if someone's depressed with their nose.
That's true to it.
No, but if someone's depressed with their nose, I don't like to operate on them, because that means that they're putting too much emphasis on something.
I guess.
Yeah, and I'm not, but if they have a really we talk about this all the time, if someone has a really well-balanced approach to their life, and something bothers them and want to do something to fix it, great, happy to help. But if their entire life is ruined because of their nose, I'm not the right doctor.
Well, I find the more I've done this, the more I find that I have to really be good up front about expectations.
Yes.
You really can't give a patient false expectations, and you really have to let them know, as long as they know what to expect, the good, the bad, usually, not always, but usually the patient will be okay.
Yes.
It's all about expectations.
Undersell
and over-deliver.
Over-deliver.
Right. And it always impresses me, your competitors who will tell a patient, oh, you're not going to have any pain. You'll be fine in 2 days. And,
right.
And I'm like, how are you telling people that?
Right.
And I remember I saw a patient in the hospital with gallbladder disease, and it was a relative of someone who worked at the hospital, a doctor. And I told the doctor and I told the patient, I said, and there was a wedding coming up. I'm like, you may not be able to dance at this wedding. You may be sore. It could be a few weeks before you could do all of that. And they decided not to go with me, and I'm like,
because of your realistic advice.
But
But that's the type of patient that we're always happy to lose.
Yeah, that's true. That's true.
I've never, one of my favorite sayings is, I've never regretted a patient I didn't operate on.
Right.
Yeah, and I think as a surgeon, we have, both of us have in our mind those cases. You're like, oh, I'll never forget that one.
Right.
And sometimes not having another one of those is okay.
Very true.
It's okay.
Yeah. What I like to say with surgery is it's very easy sometimes to operate on someone.
Yeah.
What's hard as a doctor is to decide when not to operate.
Absolutely.
Yeah.
And my field's a little easier, but in your field's, it's difficult because a lot of people, someone has thyroid cancer, they have thyroid cancers. They have to get surgery, so it's different.
But convincing someone, hey, your nose is actually fine.
I do that every day. I turn down about 30% of my clients. I have the highest turn down rate in the entire country.
Interesting.
Yeah, I turn down more patients
You do
than anyone.
injections to the nose too and stuff like that?
I do, but I focus primarily on rhinoplasty, like surgical rhinoplasties.
Right.
But I'm very, very just ethical based about it. And also, I'm spoiled because I have a very high volume.
Right.
But I turn down about 30 to 40% of my consults on a regular basis.
Nice.
Yeah, which I'm proud of. I'm super proud of that.
Great.
Yeah, that's actually what I'm most proud of more than anything else is how often I turn people down.
Do they ever then go and get a nose job and they come back and they
With
say,
someone
hey,
else?
doc, look how great I look?
They do sometimes, but sometimes it's the opposite. They go,
And then you're like,
they come
yeah.
back. They go and they'll come back and their nose looks terrible.
Right.
And they say, shit, I should have listened to you.
Right.
And, it's just one of those sad moments.
Yeah.
But, I think this was a great episode because I really feel like we got to delve deeper into a multitude of medical things and then talk a little bit about the robotics of surgery, which is so cool. People, I think, misconceive the whole concept. So we get to clear up that it's not a robot doing it. It's still Dr. Cohen doing it.
Yeah.
And then, lament a little bit about cancers in young patients and how sad it is for Chadwick Boseman. He's such a legend. Did you guys see all the Black Panther movies?
Yeah.
So good.
Yeah.
Would you
And I
recommend?
saw 42. Did you see 42?
No, the baseball movie?
Yeah.
I haven't seen that yet.
That was a good movie too.
Would you? Let's
What's
say
interesting about that guy is his career didn't hit until age 35, which is pretty interesting. So there's still hope for you.
Well, I'm working on it.
Well, let me ask you. So
Yeah.
if you had a patient who has colorectal cancer and he comes to you in your clinic and he says, well, I'm about to go start training hardcore for this movie I'm doing. It's called Black Panther. I'm going to be working out every day. I'm going to be fighting and dancing and exercising, going crazy for the next 6 months. Would you say, great, that sounds perfect. That sounds like a great plan. Or would you say, what the hell are you doing?
Wait,
Relax
so
and
that's
calm
what I
down.
wonder
What's
about.
the story? Did they tell him not to take it out?
I'm
Do
not
you
sure
know
he-
this? Did you know that?
I don't know. I know he was diagnosed 4 years ago,
Right.
which is when he was
But was it
starting to
already?
film.
So the thing about you could probably tell us better, but my layman's understanding is that once it's spread from the colon, it's too late to cure it surgically. So I don't know that.
But if that happens, it wouldn't have taken 4 years. Then he would have died in 3 months.
No, because there's other treatments.
So you have pancreas cancer on one extreme and then you have thyroid cancer on the other. Colon cancer is kind of one of those middle cancers.
Yeah.
Whereas even when it's spread badly,
treatments.
we have a lot of different treatments to offer patients, and
okay, I see what you're
occasionally
saying.
patients could be around for a long time. So that is one question I have, and I didn't hear. The only things I did hear is he was going through treatments during the movie. So,
Right.
but we don't know really what that means. But yeah, one thing I was wondering is, did he delay surgery? Did he delay treatment? Was it diagnosed late? Who knows? So that stuff we don't know. And I don't know if we'll ever know that.
No, you're probably not.
No.
Yeah, and I think it's a very fast timeline, and how much weight he lost was very fast. Because a lot of times, and this is a weird thing to think about, but when we talk about the typical length from diagnosis to the typical time of survival, it also takes into consideration what age people are generally diagnosed at. So
Right.
if colon cancer is generally I would say the peak is probably in the 70s or so of diagnosis. Those people may also have heart disease. They may also have other, may have been a smoker, which is a common thing for colon cancer. And so a lot of times when someone dies of cancer, it's because after going through these treatments, they're getting all these other problems associated with the cancer, things like, blood clots and infections and weight loss. That actually makes it come to pass. So for someone who is so fit, incredibly fit, I don't know what.
It's
Very
hard to say.
aggressive.
And
Yeah.
being active during your treatment is great.
Yeah.
But you don't know if he, you mentioned briefly Steve Jobs, who also had cancer of the pancreas, but he had a neuroendocrine cancer of the pancreas, which is a more treatable cancer. And, if you read about him, he tried a lot of alternative, wacky stuff instead of doing standard therapy. And I can't help but think that had he done what the doctors wanted him to do, he'd still be alive.
Could be.
Yeah. Which is kind of crazy. So I don't know what Chadwick Boseman did. I'm not sure. It sounds like he did go through treatment, and he may have just been someone who got an aggressive early, at a young age, bad cancer, is what it sounds like. But maybe he did say, I got to do this movie first and then I'll get treated. And it's hard to say.
Yeah.
It's hard to say. What was interesting with COVID, just a lot of the hospitals were delayed. If it wasn't an emergency surgery, they were putting them off.
Yes.
But we weren't just saying, go away, cancer patient, don't come back. We were saying, let's treat you with chemotherapy or radiation or some hormonal therapy. So I wonder, what he did.
Did that affect him? His therapies, you think, COVID?
Or did he not? Or did he say, let's try chemo or not try chemo first? I don't really know. I'm not sure.
That's a great question.
It's a bit of a mystery.
No, we talked about that before because COVID definitely has altered people's treatment paradigms.
And people were afraid to go to the hospital even.
I had people who had heart attacks who refused to go to the hospital. It was a nightmare.
Right. And we just saw The Rock, Dwayne Johnson just got diagnosed. Him and his family all tested positive.
Right.
And he had openly admitted that he feels his blunder was he had friends and family over for a party and did not require anyone to wear masks. And somebody was diagnosed positive that came over to his house. And so now he's regretfully, scared, of course. I mean, you, your wife, your kids, everyone's diagnosed positive. Very scary.
Yeah.
Very
He's
scary.
The Rock, so he'll probably be
He'll probably be fine.
Remember when you were a kid and you had chicken pox and your parents would have all the other kids come over to get chicken pox to be done with it and get over it? Do you think some people kind of feel that way with COVID a little bit?
What's interesting is I am one of those who thinks that COVID in younger people is much less dangerous than you would think. And so I think our general strategy in general, from the biggest picture to the smallest picture, is wrong. So now when kids go to college and they're having, there's 1,000 cases at college, to me, perfect. Keep all those kids there.
Right.
They're all going to be fine. And that will then protect actually
herd immunity.
Their entire families when they get home.
Right.
If you send them back home, not only will some of those people be infected and bring it home, but again, once they're home, they're going to be they're kids. They're 20. They want to go to drink at a party. They share red cups and play beer pong, and it spreads around. So to me, I agree.
They share red cups.
They do.
They do.
But the strategy, to me, I've been saying it a long time. The better strategy is preventative testing of the at-risk population. So you test nursing homes frequently, preventatively. You don't wait for symptoms, you test.
Yeah.
You test if you're going to be working inside places, you test those people. Once people are symptomatic, especially young people, it doesn't really help to test. There's nothing to do. There's no treatment.
Right.
It literally changes nothing for me to know other than to say, don't go outside when you have symptoms, which they already know.
Right.
So I think the whole way we're doing it is totally wrong personally. I do a lot of testing for...
Well, let me ask you a question.
Yeah.
Don't go outside when you have symptoms, or go outside masked and gloved and don't touch anybody?
I think if you have symptoms, you should stay quarantined.
Yeah.
Because
you can't go for a jog, you can't go for a run.
You shouldn't be going for a run if you have COVID, because it can be bad in young people and
but don't you think physical activity is actually helpful in someone?
I think people could walk around their homes or whatever, or backyards and stuff. I really don't think they should be exerting themselves.
You don't think if they have a treadmill at home, they should get on their treadmill?
I don't think so.
Even if they're asymptomatic with it?
Pretty much not, because it may end up either triggering more immunologic things just to have more inflammation going on in the body. I would take it easy. So I think most people will do very well, that are younger, not at risk.
So you don't think it's the other way? Get the immune system going and
I think the one thing that can put you, and the one thing that can be scary is if the immune system is too high and you create this cytokine storm.
Right.
As long as that doesn't happen, you're fine. So I think my personal treatment for people is I have them on Tylenol, NSAIDs, occasionally colchicine if the fevers start raging. And I'm basically just trying to give them as many anti-inflammatories as possible. and take it easy.
Are you putting them on steroids?
You should walk, not until they're sicker. So if someone is sick enough to be in the hospital or their oxygen is dropping, then dexamethasone and some of the other treatments. But when we're talking about just people at home, in general, no steroids, because you're more at risk of causing them to get a secondary pneumonia or something else than you are helping. There's some idea that people should be on Xarelto or blood thinner preventatively, because...
Is aspirin good enough?
So if someone's fevers are not that high and they're still moving around, that's what I'm doing.
Mm-hmm.
If someone is sicker where the fevers are high or in the hospital, I mean, I'm doing Xarelto on all of them, or one of the blood thinners or blood thinners. Because again, the COVID
zinc?
causes...
Do you believe in zinc?
Yeah, so the thing about the zinc and the vitamin C and all these things, what we don't know and why we need trials and better data, which we don't have, is are you making it worse actually by stimulating the immune system?
Right.
Because the other side of it is, what are the treatments that are working? Dexamethasone, so turning off the immune system, works. All the people who want to say that, what's it called? Hydroxychloroquine works. What does that do? It slows down the immune system. So most of the treatments that are working, the IL-6 inhibitors, all the things that break the cytokine storm, are stopping the immune system. So I really don't have people taking supplements or vitamin C drips. I'm scared of the doctors offering things like stem cell treatments and trying to boost the immune system. I don't think those are helpful, especially for the people who would do fine anyway, which are most people under 50 that don't have comorbidities would do fine anyway. So what we're really doing is protecting the at-risk and elderly. And
do you know the fatalities in kids?
It's very low. So there are fatalities.
Yeah. In totally healthy kids, or they're sick kids? I think
so. It's like, but the thing is, we don't know what the denominator is. So it's like less than 100, I think, cases total in the US of children. Yeah. But obviously, if it's your child, it's less than flu. So we think the percentage of them, it's less deadly than RSV in children and less deadly than flu in children. Right. But it can kill. It has.
Should we open schools?
I sort of think so.
Yeah.
I sort of think so.
We should make it all boarding schools or just keep them in school.
That would be helpful. To be
really
for herd immunity, like we're saying.
Well, again, the reason schools are dangerous is the children can go and then they come back
home.
And they give it to their parents, teachers, grandpa comes to babysit. That's the risk. There's there is risk in the children. We can't say there's no risk. Right. But if we're trying to figure out how to make society work the best we can, it's just most parents, and my friends, a lot of them have young children, they are not doing that. So what a lot of my friends are doing are these little school pods, where they're taking 3 to 4 families, and some of them are actually testing also. So they're testing the teacher who's going to be watching the kids. But there is risk.
Do you have kids, Dr. Cohen?
I have 3 girls, yeah.
Are they going to school?
One graduated college already, Berkeley grad, and then the other 2 are remote. One's in 11th grade at Beverly High, and one's in 9th grade we just switched her to a private school, and so she's remote. Yeah.
From home.
Exactly. Started today.
She got a refund.
Started today. I know, right? Exactly.
Where's she going?
To Toledo.
I don't know that one.
It used to be called New Jew.
Why not Beverly? Good old Beverly.
She was in the Beverly school system, and we decided she's someone who would be better off with kind of more of a smaller, more attention. We thought she could get lost at Beverly.
I loved Beverly.
My 2 eldest ones did Beverly.
My pops went to Beverly too.
Oh, wow. Yeah. Where were you in little kid school? Beverly Vista?
I went to El Rodeo.
Okay. So she was in El Rodeo, the one who we switched out. Okay. And then Beverly Vista became a middle school.
Right. Yeah, now El Rodeo doesn't exist right now. It's under construction. It looks now so weird. I didn't know it.
Is that the one on Wilshire?
It's the one on just north of Wilshire on Alvarado.
Yeah, I think so. Yeah.
Okay.
On Whittier.
Yeah, Whittier. Yeah.
Anyway, I personally have to run, so I'm going to have to cut this beautiful conversation short. As much as I've
Before you run, can I just make it one little thing?
Yeah, we're going to do 2 things. We're going to plug you. First of all,
that's what I wanted to talk about.
If anyone needs their thyroid out, now we know who to call.
Now you know who to call.
But also
and it's
you
not
have your,
Ghostbusters.
But
it's
also
me.
you have your own podcast, right?
Right, and that's what I want to talk about for one quick second.
Yeah,
so I have a podcast called, but not so much that, but about you being on my podcast.
Yeah.
So the podcast is called Gross Anatomy Podcast.
I love it.
And
Where can
the
they
whole,
find it?
It's everywhere.
So
And Instagram.
on
Apple.
Spotify,
Spotify, Apple.
Yeah, perfect.
We have our own website, so it's on our grossanatomypodcast.com website. We have an Instagram, Gross Anatomy Podcast.
Wonderful.
And our whole thing is, I'm a big movie pop culture fan, so it's I said it already before we started. We explore the sights, smells, and sounds of medicine and how it relates to pop culture, movies, TV, and the world around us, and books. And actually, my fantasy with Gross Anatomy, and maybe that's something we could do together, is to actually have like a coffee table Gross Anatomy book where it's gross, disgusting pictures of stuff, but like high end, shot by paparazzi that people would love to kind of see. I don't know. That was one idea. But so, Jeff, you came on the podcast and we basically talked about COVID the whole time, but we have an Instagram for it. And what was really funny, I hope I don't embarrass you, you could always edit this out. After the podcast, I got so many DMs, the nurses in the ORs, everybody coming up to me, my kids, their friends saying, is Dr. Jeffrey Toll single? That's what everybody wanted to know. I had random people DMing me, random people messaging me. Everybody came up to me.
Disappoint them all.
I know. It was very upsetting. There are very sad Gross Anatomy listeners out there right now.
Yeah.
I still like you to listen.
McDreamy.
Right, exactly.
You can still listen.
I call him McDreamy.
There you go. Exactly.
Yeah.
But it was a fun episode. Thank you for being on it.
Yeah.
Well, thank you for being here today
Thank you.
on Modern
This was
Prescription. Great episode.
it.
We had such an honor with Dr. Cohen.
Jason
Cohen.
There you
go. A great episode, Dr. Jason Cohen. We really
Thanks.
appreciate you being here.
This was a lot of fun.
Amazing insights and continue helping the world at Cedars-Sinai as a specialist.
Thanks for being on.
Thanks a lot. And now I know where to send some noses.
Yeah, should you ever need to.
Exactly.
Or if you just need me to say no to them, I'm happy to do that.
Perfect. Exactly.
Thank you so much.
Thanks, guys.
All right, and thanks for listening. It was a great episode 12. Or hope you guys learned a little bit. Talked about a lot of stuff.
That was a good one.
That was a great one.
I think people should be really sharing this a little more than they do.
Please do. Please share it, like it. Ask us questions. Whatever you want us to talk about, we're happy to.
Like there was only like 300,000 shares this week.
Yeah, we need
up more.
In the millions. Up in the millions.
Come on.
Crank those numbers up, baby numbers.
So keep liking it. And if you want to send questions, we today ran a little long, so we didn't get to the questions, unfortunately. But send some questions and
yeah, we can't wait. Keep listening. We have some really cool episodes, really cool guests coming up, so we can't wait.